Nor.
All right. So here we're going to go over the critical care environment. We are going to review the central line a little bit. You are going to get tested on that. Then going over the hemodynamics, arterial lines, Swan's grants, catheters, just a quick um, kind of basics on some of the IV medications that you'll see. And then some mechanical ventilation. I mean, most important thing is going to be your VAP bundle. You're going to need to know this. And then we're going to try to combine it's like questions plus, oops, you saw
The
the answer.
answer's no.
Sorry, they don't remember. The questions alongside the review content. So it's going to be kind of like we go through a section, you have questions, go through a section, you have questions. So you'll have like a more complete kind of thing. Yeah. So when it comes to the critical care environment, this is something I think you guys went over in PowerPoint. It's just kind of here, it's just kind of listed down some of the examples of patients you'd see in the ICU. So specifically, septic shock patients, they're not responding well to treatment. And then here is some general things. You don't have to memorize anything here. Your first test, assuming it's the same, I believe it's going to be hemodynamics. Um, for your first exam, other than the math, it's like it skips week 2 if I recall. You don't have to do EKG until later. I think your first test is week 1 hemodynamics. So whatever you learn week 1 is what gets tested, not counting because you do hemodynamics week 3. I don't think it includes that one, if I recall. But yeah, here's just like some examples. So septic shock, there's systemic vasodilation, you have edema, patients don't potentially don't react well to the fluid boluses, so they might be on IV drips, vasopressors. Um,
Professors.
and other kind of patients, respiratory failure, ARDS, people that need mechanical ventilation, people with DKA, HHNS that are going to need insulin drips. They're going to need to have their metabolic, if DKA, metabolic acidosis is going to be managed. All of that stuff. The Whipple, so some post-op patients like post-CABG, post-Whipple, patients
Yeah.
that after surgery need a lot of monitoring, major burns. So here's just again just a super simple idea on each of these. You don't have to know these. You'll learn more about everything listed here later, but here is just like an introduction. So with burns, I'm sure you might have seen some of these on Kaplan stuff. I think while doing like your F&E, it just randomly gives you, well, it's not really random, but it gives you some burn questions. So there's electrolyte shifts in burns, shock risk, and then because everything's like an open or it can be open, hits you with some infection as well. Trauma patients, patients with spinal cord injuries, MVAs, lacerations, internal bleeding, as well as like severe electrolyte imbalances for people having really bad hyperkalemia, people with severe hyponatremia, seizure risk, for whatever reason they might have it. So here's just like basic idea just to kind of get the gist of it. So
I do
go
want
on.
to ask, what is something that you guys see in common with all of the patients that could be in the ICU? It's like, these are all different etiologies, right? So we see
Hmm.
sepsis, we know that's infection. Respiratory failure can come from a plentiful of things. DKA is glucose regulation, but what do all of these specifically have in common that puts these patients into the ICU? Hemodynamically unstable is one,
Hmm.
definitely one. What else? Mhm. Hello? Mhm.
It's mumbling. I can't hear
I
it.
was like, I'm not sure, but okay. Yeah, respiratory continuous monitoring. I mean, continuous monitoring to an extent, right? Like we can definitely see our patients on tele with tele boxes, and that's technically continuing. And some of them also have continuous pulse ox. But it's basically anyone with an issue with their ABCs or a very possible issue to their ABCs. So with our septic shock, You might see your patients with sepsis on the floor, sure, and they're being, yeah, definitely unstable. You might be seeing your patients on the floor with sepsis that is controlled with antibiotics and fluids totally fine. They're hemodynamically stable. But once you progress into septic shock, which you guys will learn, I believe, in week 5, those fluid boluses aren't enough to keep their blood pressure up. So now we have a problem with our circulation at this point. So that places them there. Anything that really needs a drip as well. There's the rare occasion that you'll see a drip outside of the ICU, like heparin drip, you might see in a tele unit as well. Respiratory failure, someone who is on a mechanical vent, who declined very quickly, that person has an airway and breathing issue. DKA, all the electrolyte imbalances there put them at risk for airway, breathing, and circulatory issues. So all of these are just, they connect in that way. So ICU is like the absolute worst of the worst. Something is very, very wrong with their ABCs, and if something's not done, they will die. That's kind of what I want to get to with that. Okay, I'm done talking for
Yeah,
now.
they call it the ICU because you're monitoring them often. ICU.
I see
Anyways.
you, girl. I see you.
Yeah, so this is another thing that Professor Brooks mentioned, and I think it's good to keep it in mind, just as like a nice little mnemonic cheat sheet kind of idea. They talk about confusion in this case, like delirium and all that. So in general, kind of have these concepts in mind. So when you have potential delirium, think toxicity, hypoxia, infection. The N is a little bit vague, so it stands for like non-pharmacologic. I listed down a few examples of some things that would fall under here. So dehydration, hypoglycemia, thyroid storm, and then K for potassium. But then it's kind of like potassium and electrolytes. So I do think it's helpful for remembering um, all the like a lot of these causes for acute confusion slash delirium at once. So I think that's a good thing to keep in mind. It may show up as a select all that apply, maybe, perhaps. All right. So let's see. Now let's go do the central line review. So I did list here some reasons to insert central lines. So it can include a patient that needs TPN, uh, patient that are receiving vesicants IV, long-term IV, so things like patients being DC'd home with antibiotics, chemotherapy, or even because they're difficult to find the like it's like a PIV to get in there. I've had that happen where they could not find even with the vein finder, they struggled. They were looking at the shoulder, so minors failed too. This is before we were allowed to do the sticks on the patients because we didn't get to the CPE yet. Um, she got a second nurse to help out. She also failed it in 2 sticks, so they just like called someone to put a central line in because they couldn't
They'll
get
call the poop
one.
team.
Yeah, couldn't get one, or it just like blew out when they tried it. And here are the 4 types. So what I want is for you guys to tell me what are some things that differentiate like a non-tunneled versus some of the other ones. Like what advantages, disadvantages, just kind of like the very basics, nothing too extreme. I mean, this is just review, but you will be tested on central lines to some degree. So you will need to know. Um, so 3 lumens for ER situations, you remove. So yeah, so I think yeah, just keep launching whatever ideas, whatever thoughts you have, and I'll write the ones. I'll try to just write the ones that I think are probably the kind of most basic, simple stuff to keep in mind. Yeah, so this is more shorter term and usually used for emergencies. You can just kind of place it. What else? What else comes here? Easy to remove. Um, some have a higher risk of infection. Yeah, so that's higher risk of infection for sure. What else can you easy to remove? Yes. So use for emergencies. No need for surgery. So shorter term use for emergencies. No need for surgery to place or remove, higher risk of infection. What else is key when it comes to the non-tunneled? Where is it? How is it being placed? Where is it being placed?
Subclavian.
Yeah, so you typically it's in the subclavian. So like so just like Jude said, and then like Jessica said, there's a risk for pneumothorax. Risk for pneumothorax. So what do you need to do after placement of the catheter?
Wait,
Chest X-ray.
Yes, so you're gonna need to do a chest X-ray to confirm placement, but also to make sure the patient didn't get a pneumothorax.
Is air
Okay.
embolism air embolism a risk for that also?
It'd be definitely a risk when you're taking it out. So we can talk about that when we get to complications. But yeah, so we'll mention pneumothorax, we'll mention air embolism. When we get to this, we'll talk a little bit more about it. But yes, that's good. Anything else to add, Kaylin?
let's see. I'm trying to make sure I don't double question stuff, so I'm like, no, I'll go through it in the questions at the bottom.
Okay.
Requires doesn't it require like daily flushes? Should you put that down? For non-tunneled?
Yeah, could be good. I mean, I think for the most part, they're all gonna they're all gonna really need the flushes to make sure they're good. But let me see if there's anything else here. Blah, blah, blah. Yeah, I guess that yeah, that goes in there. So we'll just include it just to keep it simple. You do need daily flushes. A lot of the IVs will need that sort of management. Okay.
Is this
Pinch off.
is this the catheter where we only do 10 ml syringe? Or is that for something else?
I know what you're referring to. So that's the pressure. I think in general that's just for all the catheters. So the idea would be the 10 ml syringe has if you use a different pressure, it causes some issues. Um, I think that's just all of them in general. But I do know what you're referring to. Okay. I think other than that, that's just again we're gonna try to keep it simple. So that's as simple as I'm looking for. Shorter term, it's used for emergencies. Risk for pneumothorax, so you need a chest X-ray. Higher risk of infection, and then that's good enough for me. So what about the tunneled? Okay, so we have underskin, therefore less risk of infection, long-term use like chemo. We have Ryan mentioned needs surgery. Yeah, so this is surgically inserted under the subcutaneous fat. What's going to be a tunnel, compared to one tunnel, less risk of infection compared to non-tunneled. What else? So yeah, this is for longer term use, car surgical removal. Anything else? So even though it is sliding through the subcutaneous fat, where is it inserted into? Yeah, it's going to be external access. It's going to be harder to pull out. There's going to be some body image disturbances. So where is it inserted into? So I'll get a picture. It's still, yeah, it's still the subclavian. So you see here, I'll probably zoom in, maybe get a little bit of that. It's going to be here. This is the non-tunnel. It's in the subclavian. Makes its way here. Versus the tunneled, it's still inserted in the subclavian, but then you still have this extra bit of tubing that is then placed underneath the subcutaneous tissue. So that's why it's tunneled. So it tunnels out and then comes out here. So it's still external access, just like this one, but there's a little bit there. Yeah. The little subcutaneous fat kind of acts like a shield from that helps it makes it bit less prone to infection. So because it's still subclavian though, that means we do have a risk for pneumothorax, so we're still going to do a chest x-ray after. So we see some similarities already. It's for pneumothorax. So that's things to keep in mind about how some of these are going to be very similar. Okay, now let's get to the nitty gritty for the PICC line. Yeah, so that's a big one that separates it. So yes. So why do you measure the circumference of the arm? So that's going to be something we'll need to measure the circumference. Spelled that wrong. There it is.
Mm.
Yes, to assess for clots. So yeah, so this one is a peripherally inserted central catheter. So it is going the same place in those veins, like in the middle of the arm. So it's going to go in there and it's going to make it its way all the way into the heart. Same position here. So because of that, yes, there's virtually no risk of pneumothorax because it's not going to be going in from an area can be that can hit the lungs. But are you gonna so do you want to do a chest x-ray? Yes, so you're still going to want to do a chest x-ray even though we are not going to have that risk of pneumothorax just because we still want to confirm um yeah, the placement. So let me just okay. So yes, we're going to want to do a chest x-ray to confirm placement. So the heparin flushes depends on the facility. Some places don't do heparin flushes anymore. Some places still do heparin flushes. Yeah, so chest x-ray to confirm. I say it's for short to intermediate therapy. So tunnel, it's longer term than the non-tunnel, but it's still not for super long term, like not super long term. But just the PICC line's like intermediate, short to intermediate. What else do we have here? Just inserted peripherally, so see inserted in a peripheral vein, so virtually no risk of pneumothorax. Yes, so that's going to be a big thing is that patients should not have their blood pressure taken on the arm that their PICC line is placed. And they should also be careful not to, yeah, so Kaylin asked you. So I was going to say it, but Kaylin wants you guys to answer it.
My bad.
I like that.
No.
Yeah. So no BP on
We love
arm
the signs.
Yeah.
Ryan said very demure, very mindful. Very mindful. No sticks,
Yes.
no venipuncture. Stick.
Yeah, so be careful of exercise lifting, moving it too much. No blood pressure on the arm. You don't want to ruin it.
Soiled it.
Measure for circumference for the arm, test for clots. You're still going to do a chest x-ray to confirm placement, but there is not that same risk of pneumothorax. Okay, that seems good enough to me. So let's talk about the implanted port. So this one is going to be short-term, long-term. Yeah, so this one's very long-term. This is your most long-term one. Functional for years. We're talking about years here. yeah, you're gonna need the Huber, or it's also called the non-coring, yeah, non-coring needle. So we're gonna need to do requires access. What else? It's pretty much not too much. I guess surgery. You need surgery to place and remove.
Oh yeah.
This one, they specifically said flushing. Just kind of give you a general estimate with heparin. This one requires heparin. Is it painful to get the core? Oh, Caitlin knows says can be when assessed initially. Yeah.
For you, but someone digging a Huber needle into my skin.
Oh,
Mm-mm. But other than that, it shouldn't be too painful. I mean, after the initial insertion itself, sure, there might be discomfort. It's definitely a new device under the skin. But over the course of time, it'll just kind of be there. And the only discomfort at that point would be during accessing. Otherwise, it's just a part of them now. Besties.
all right. So we talked about complications. So pneumothorax, air embolism, anything else you guys can think of that can occur. And we talked about clotting, so we talked about thromboembolism. Anything else that comes to mind? Arrhythmias kind of goes with all these stuff
Infection.
here. Infection, yeah. So CLABSI, that could happen to the mouth position. Sure. I'm gonna just write down the most pertinent ones. There's also like accidental removal and whatnot, but let's just talk about some of these. So pneumothorax. When it comes to a pneumothorax, what is your intervention? Just like let's get like maybe like 1 to 3 points across. Sure,
Um,
yeah, sure. What about like treatment for pneumo? So I'll kind of have signs and symptoms, just like a quickie. Patient's gonna need O2, chest tube to try to get some of that stuff
later.
out.
Hey,
All right,
girl.
cool. And then what are some signs and symptoms of pneumothorax? Just like quick and dirty. Shortness of breath, dyspnea, like it. Yes, so tachycardia, and I'll throw in pleuritic, chest pain.
Wow.
So meaning it hurts to breathe. It hurts to breathe. Decreased lung sounds. Yeah. So all these are good. So
On the
if you,
affected side.
yeah. So if he throws in a SATA, you know what to put. All right, cool.
Dang.
Cool. What else?
It was
Uh,
mentioned earlier, arrhythmias was mentioned.
oh yeah,
It's somewhere up at the top somewhere. I saw it. I don't know how to spell it. Forgive me.
it's okay. What about for air embolism? I think the main thing you need to know is like the intervention and maybe some of the signs and symptoms. Usually very similar. You'll see very similar signs and symptoms to your pneumothorax, and very similar symptoms to your pulmonary embolism, very similar. So you'll have like, yeah, so like tachypnea, tachycardia, chest pain. Yep. So your interventions are going to be for you to go into the left side, patient put left side and placed in Trendelenburg. And the point of it is that if there's the air embolism, it traps it in place so it doesn't move and move somewhere else until it goes away. What would you do to prevent it from happening in the first place? Yeah, cool. So yeah. Yeah, don't laugh. I don't know why why they'd be laughing. I like that one though. Because I know that's how he said it, but I think it's funny.
No, I think I did a question like 232 and I think I was like, "Oh yeah, the patient like makes a joke and laughs." And then all of a sudden they end up with a
That's
with a tremble.
here's the real question. Is it bear down or bear down? Which one is it? Vote vote in the chat.
BARE.
B A
The
R
second
E.
one. Hmm.
Looks
What?
like
The other one,
there's discussion in the chat.
Oh my gosh, wait, hold on.
you guys are tripping me out. I think it's the second one.
What,
I don't know.
no, wait, no, it's bear like the actual animal. I'm looking at it.
Yeah, it's bear like the animal. All right.
See
Oh,
it.
I'm wrong. Thank you.
Bro, you had me tripping out for a second. My second language. I love that. Girl, it's my first and I still don't know what's going on. It's all right.
I've been feeling it the other way.
I was like, as long as we know what it is, it's all right. Or you know what? Just be bougie and say, whoever said Valsalva earlier,
Yeah,
that's
the
bougie.
Valsava.
That's super bougie.
I like that. Okay. Let's
Ooh, ooh.
imagine you get quizzed on that for no reason, like spelling. No, that'd be
Like
crazy.
that'd be the type of teacher that you would be. Just a troll.
Me? No.
Yes.
No.
He's so shocked. He's a blank. Bruh.
And there's clots.
What?
This is just kind of like report, and then they'll figure it out. Thrombolytics. But yeah, to
Measure
prevent,
that arm for that.
huh?
Oh, so measure that arm for that
Yeah.
pick.
Well, you don't really prevent by measuring, but
Oh yeah,
opportunity.
don't fall for don't fall for that,
Yeah,
please. The wording, man, semantics and stuff.
semantics.
Above our pay grade. Love that for you, girl. Yes.
Says cool or warm washcloth to arm. When it comes to that, I believe it should be cold.
Wait, where do you
The
see
idea
it?
being that it
Oh, I see.
constricts, therefore it doesn't make it kind of dislodge or kind of keep going. So
I've
measure
seen
arm, but it's
I've
up
seen
to policy
arguments on both
apparently.
sides of it.
I've seen arguments on both sides, so it's up to your policy.
Yeah, I was gonna say I was like I ain't gonna talk on that one because I've seen both sides to it.
Yeah,
Definitely don't massage it though. Like that's a hands down
yeah,
one.
definitely don't massage it.
Flush it frequently to keep patency.
Yep,
Yes,
I
that's
like it.
definitely a good way to prevent that. Just don't move it. Just don't move the arm. Just stabilize.
Just stay.
Just stay there.
All right, so now there's Clapsy. So we're gonna talk about the save because who knows? It might come up literally. It might literally come up. All right.
I love that acronym. I think
I
it's
love
so funny.
scrupulous. I love that one. Scrupulous hand hygiene.
You're the scrub.
Scrib.
Scrub.
A4. You got someone already said.
Definitely sterile procedure when you're changing that. Definitely so.
Yeah, we're definitely gonna do aseptic technique. Vigorous. The vigorous. Friction to hubs.
It was so ridiculous it stayed in my head.
And intrapatency. Yeah. But it does come up. So just to iterate, usually will happen 2 to 3 days after insertion. If you get fever in the same day, it's probably something else. Infection takes a little bit to get going. I like it, yeah. I like that. So like assess for the need to maintain a central line.
Darn right, Ryan. Take it out. Take it out if it's not needed.
Yep.
Chlorhexidine
Chlorhexidine.
for days.
True.
For days.
We do be cleaning with chlorhexidine.
Hexidine wipes.
Yeah.
The bio patch.
True. The bio patch.
Oh, bro.
What's it?
I don't know why that just like reminded me of that one clinical day I had where we were doing the central line dressing change. I don't know, I'll talk about it later. It like popped in my head right now. I was like, oh wow, forgot about that happening. Good times. All right.
And this one's just like,
Arrhythmias.
just depends on what it is. It's not much. Depends on which arrhythmia you get. And then nursing considerations.
Yeah,
Yeah,
pull
so we're
out
gonna
if
talk about.
migrated in.
So remember your pull-out game is strong. That's what you gotta remember.
Sir, this is recorded. That's what he what?
I knew it. I knew it. I told you. Yeah. Him
No!
and I, Jim and I, we know, we
This
got
is
it. Like
terrible. This is terrible.
Harold.
Harold! Harold! We love that. We love Mr. Robbins.
That's how I remember. That's like genuinely how I remember it, is because I just say pull-out game strong, and that's how I remember it.
You are terrible. You are terrible.
If it helps me remember, then it's just a good idea.
I guess.
All right, wait till he says the other thing he says. That was funny.
I think that's coming up this
It's
upcoming week for them.
is it week 3?
It's week 3.
Love that for you
Someone
guys.
said drugs and amphetamine can cause tachycardia, and he's like, oh, the good stuff. I could totally see him doing that, which is the worst part. He's like,
I love,
yeah,
I
good
liked it
times.
when he was in our class. He's like smoking a little weed, huh? I was like, what? Remember that, Galen?
I forgot what he said that for, but I do remember that.
He was just asking ways to not ways to like help with pain management. Someone's like THC pills, like smoking a little weed.
I remember, yes, good times.
Yeah, so this is gonna be up to policy. So, but yeah, like around 7 days. Change or even PRN depends on.
Definitely pure. And
Mhm.
if it's coming off,
Yep.
if it's nasty, if it's covered in blood
Mhm.
or other fluids and whatnot,
Mhm.
mm-mm.
What's the dressing on it called?
A dressing, I don't know.
Like a
Take sure.
yeah, it's like a transparent film dressing.
I was like, wait, why are you asking?
It's a transparent film dressing. And it is not a sterile gauze. All right.
No gauze.
Yeah, it
Why?
is
Because you
not.
can't see through it.
Yeah. Oh, I'm saying this for a reason. All right. You'll thank me later.
Stay salty. Stay salty, my friends. Tegaderma is sterile.
Yeah.
He's just referring to no sterile gauze.
Yeah.
Because your gauze versus your tegaderma are going to be two different
Yeah,
things.
they're not. Yeah. It is the dressing is not a sterile gauze. It's definitely not a 4x4 sterile gauze. Yeah, and other than that, it's like allergies. So you guys remember when you're doing your procedure that you're going to make sure the patient's not allergic to chlorhexidine. Or yeah, or like tape or like whatever.
Poor girl Jessica. Jessica, no.
Yeah, just and then similar thing to when you're doing your PIV, you're going to be assessing the site and catheter. All right, that's pretty much it on that. Do you have any questions for this part, Kaylin?
For the where are you at right now? Sorry.
Just
I was
finished central line.
yes, I do. Sorry, I was tippity tapping. I'm on the wrong document. Oh my gosh. Okay, here we go. Yes, I do. It
So,
is questions 1 through 7
all
at the
right,
bottom.
1 through 7. So she's gonna take it away now.
Take it away, take it away, take it away now. All right. These are kind of just more talking points than anything. And then I have like the very occasional question thrown in. It's been a busy week. Please
Holy sh!
forgive me.
My campus says 100 notifications. That's crazy.
Well, my work one's broken. Mine doesn't say anything.
I know. I think it's my BSN one.
Oh, bougie girl. Oh yeah, people are responding like crazy. Okay, in any case. So this is kind of just going over really basically the stuff we just talked about. I have more for A-line and PA cath, and then I have one question for mechanical vent later on. But in terms of your critical care environment, first question, you're a nurse in the ED assigned to a patient requiring an emergent central line insertion. What type of central line would be best for this patient in this situation? Cool beans, guys.
Cool beans. So yeah, this is the non-tunnel. So that's the one you can just kind of do. It's like emergency.
Smack it in.
Smack it in, yeah. It doesn't need surgery to place or remove. Doesn't have to be, it doesn't have to be snaked all the way through with like the PICC line. Not a port, like a little implanted port. Who's this?
Hey.
All right, so that's the answer to that. Number
The
2.
answers are also on the bottom, but pop
Oh,
off
true.
queen. Pop off queen. All right.
True.
So number 2, patient received that central line from the previous question, aka they get the non-tunneled. What is your main complication to assess for that specific central line?
We just talked about it, so you guys should all be able to instantly know it.
Thorax. So how are you assessing for that?
Hold on, there's 18 people assessing for teachers in the chat.
Is this
All right, we're
patient,
good.
can they breathe? Shortness of breath, their vital signs, shortness of breath, chest pain, absent lung sounds, specifically on the affected side, chest x-ray, respiratory status. Yeah. So in terms of also knowing your chest x-ray, also know what you can do at the bedside to really assess for this. So what assessments you can do. So shortness of breath, tachypnea, dyspnea, diminished or absent breath sounds on the affected side. Let's see, head of bed up. We could try to promote that little side other lung to expand. Where do I see vital signs? What kind of vital signs do you expect? It's like I know something else. I love Michelle's comment. Can they breathe? I hope so. Heart rate up, respiratory rate up, tacky. Pretty much O2 down in the dumps. Start to go down in the dumps. Cool beans, guys. Yeah. I don't know, like when I was learning this initially, I was like, yeah, just get a chest x-ray. And it was like, you should probably know what other assessments to do. I was like, oh, right. So, you know, just in case. Cool beans, guys. So number 3 is an actual question. You're preparing to transfer patients from your ED. Which of the following patients should be transferred to ICU first? Because we love priority questions, right? That delegation stuff, that prioritization stuff, it never went away. It follows you.
Yeah, so it's not included in here because it's kind of just like priority question, like the priority part. That's the review. It's review, but it's like the exact same type of stuff where it's like a priority question. Can the LVN do this? Can the CNA do that?
Now we're dealing with people's lives. With their lives. I'm having too much fun here. I'm sorry. Cool beans, guys.
Cool.
Out of curiosity, is there anyone who wanted to choose D, a 45-year-old male, history of hypertension with chest pain and normal vital signs? And if you did, why'd you want to pick it? If not, why did you not want to pick it? No, I'm just asking. I'm just asking. It could be an MI. Vital signs are stable. A, B, and then C. True. This is definitely more of a, I definitely need a little bit more information, right? Probably not something you would see in critical care. I mean, unless they had a STEMI. We do have a lot more info on C that is extremely concerning. They're in acute respiratory failure. They probably are going to be intubated real quick, real fast. So this person's going downhill first, and 2, our ABC priorities, airway and breathing, are down in the dumps right now. In terms of D, there's definitely a lot of information still missing. I can kind of make assumptions or differentials on what's going on. They're here with chest pain, normal vital signs. The normal vital signs, it's like, oh, that's kind of odd. So why are they having the chest pain? I need a little bit more info. What type of chest pain is this? What have they done for it so far? Did it present, I don't know, after a spicy meal? Because let's be real, it happens. So I need more information specifically for D before transferring that patient to the ICU, if anything. Let's see, vital signs normal plus circulation problem, breathing. Yeah, cool beans. I just wanted to throw a wrench in your guys' plans. Don't worry about it. But yeah, the correct answer for this is C, because this patient If they don't improve soon, we'll probably be intubated. Cool beans, guys.
Cool.
This one's so big. I realize you didn't even go over this one, so I'm not even gonna keep it
Nope.
here.
Oh, okay. Oh no, keep it because it's like so my thing here was gonna be like when you come back to study for study, come back to it like a week later, you have this stuff filled out, the outline filled out, and then you have questions that you could answer to kind of quiz yourself. So it's fine. You have as long as the answer is down there, then no reason not to.
Okay, cool beans. So you are the nurse newly hired in the ICU. What is your role? And this is pretty generalized. I know Brooks talked about it very briefly in class with you guys on week 1. Slave. Oh my God. Oh my God. True. Communication with the family, very important because there's a lot going on. They're going to be worry rabbits. Vigilant assessments, advocacy is a very, very big point. 1-to-1, sometimes not 1-to-1 though. 2-to-1, if any. 3-to-1 if you're very unlucky. 3-to-1 would be technically not legal in the state of California. But yeah, advocacy is going to be very big for your patients in the ICU because let's say that patient from the previous question did end up being intubated and being sent to the ICU. This patient can no longer talk for themselves. They're on sedation, they're on probe, and they can't do nothing for themselves. So I need to be the person that says, hey, this patient is not doing well. I need this for this patient. Definitely a lot of collaboration with interdisciplinary teams, which actually I was going to talk about because I know at PIH, if you are at PIH and you do get an opportunity to go to the ICU, you'll see that they do rounds. And it's not like the rounds where it's just like the doctor and like one other person in the room. No, it's like everybody that's involved in the care team. So you have your PT, OT, the doctor, all of the doctors that were consulting on the case. You have the nutritionist, the pharmacist, you have like everybody there. So a lot of collaboration with interdisciplinary teams. Manage family and all of the medical team, quick and accurate assessments, recognizing subtle changes. It'll be the littlest things that will throw your patient into absolute chaos. Ooh, also having good emotional intelligence regarding the stuff you interact with. I do want to question what that means. I think I know what you mean by it, but I want to question it. If you would like to talk about that in detail. Family dynamic. Oh, yeah. Don't walk into the room and be like, "Oh, so you're Mr. Smith's daughter?" No, I'm his wife. Ooh.
Ooh.
Read the room, girl. Definitely so, because I learned that lesson real quick. Let's see, quickly noticing, see a change of condition. Yeah, cool beans. So noticing, I think the acronym that was given to you guys was NUR. Notice, interpret, respond, and reflect. So it's basically your nursing process, right? Trending and recognizing your subtle changes, thorough and holistic approach to care, because we need to take everything about this patient into consideration. If I continue to, give them a whole bunch of pressors and antibiotics and I'm overloading them, okay, now I'm sacrificing the kidney. So I have to look at the patient as a whole. Why are you highlighting? Oh, there, I was like, why are you highlighting this?
Yeah, so that way they can follow along, and then I'll go back to the question that's not fill in the
Oh,
blank.
cool. Bet. Main source of contact for family members of patients, advocate, big one, coordinate and protect. Yeah, especially, as a new grad, guys, like, even as a nursing student, it can be kind of hard to advocate at this point because we think that we see something or we know that we see something, but we're trying to figure out how do I bring this up and should I even bring this up? So, as you get more comfortable with your assessments and you get more comfortable in seeing stuff, you'll be a better advocate for your patients. But, if you're not ready to fully advocate to like the doctor yet, bring someone else, bring another nurse and be like, I think that I see this. If you're not sure, I think I see this. Can you confirm this? Get their opinion on it. What should I do? Should I call the doctor? Yes, you should call the doctor. Okay, I'm gonna do that now. Get your little backup, get your squad together. Okay, that's it for that one. Up to 5. That was 5 is so vague too. I'm so sorry. I'll add a bit more context into it. So your patients in the ICU, obviously we just talked about there's a lot of extra stuff that goes into this. There's a lot more care that needs to be provided. So these patients all have special considerations. So what are some that you can specifically think about for your patients in the ICU? Oh, honey, why are they there? Is there a reason for them to still be there if they had been there for a long time? Are they ready to be downgraded as well? Um, there was a stroke guy, I think on my last clinical day or the second to last one, and I remember walking into the shift and being like, why is this guy here? Like he's chilling. He's been here for like 3 days. He's totally fine. Like, and sure enough, they ended up advocating, hey, this patient probably shouldn't be in the ICU anymore. There's no indication for it. And they downgraded him. Lots of IV drips and tubing. Make sure that mess is sorted out. Yeah, you will quickly figure out why in third semester they were so on you about where's all your lines? Are they all labeled? You know, what connects to what? Follow your line. Yeah. There was a patient I saw, he had a triple A and he had, oh God, I don't even remember how much stuff attached to him. He had a chest tube, he had a Foley, he had this draining device on him. So that's already 3 tubes down at the bottom of his body. And then he had all these different drips. He had like 6 or 7 different drips. Plus he had a arterial line and a PA cath. He had a lot going on. Miss Girl had a lot going on. So it was very important that everything was labeled to the best of their ability. Skin breakdown. These patients are very, very big risk for skin breakdown. So when you go to the ICU during your shift change, a lot of times they'll do a skin check. So you literally go in with the other nurse, you do your bedside report, and you will basically like move the patient over if they already had a pre-existing wound or skin breakdown or wherever the pressure ulcers. You'll talk about that one, you'll look at it together and then document it later. It's just because these patients, if they're sedated, not moving around, they're probably gonna get a pressure ulcer. Oh yeah, AAA is an abdominal aortic aneurysm, forgive me. Not the car, not the car insurance. Sorry. Yeah, bed rest will present high risk for clots, DVT prophylaxis as well. So that's your SCDs, your heparin. You could see that as well. Just depending on the situation, what's going on, there could be more caution used with your anticoags. Managing pain and sedation, that's a big one too. So especially pain, right? Like, let's say that patient did go get intubated, he ain't there. How is he going to tell me he's in pain? So I need to be able to do a nonverbal pain assessment, and if they are verbal, a pain assessment, a regular pain assessment, our PQRST. Our sedation, if they are on sedation, I need to know what the sedation goals are, and you guys will learn about that, I believe, in week 4 with your mechanical vents. The sedation goal, am I over sedating the patient? Am I under sedating the patient? Where should I be at? And our sedation vacations, which is another thing with our mechanical vents. We need to kind of wean them a bit. It helps in the weaning process so that they're not just continuously sedated. Reorient the patient to prevent ICU delirium, because let's be real, I don't know about y'all, but I've been stuck in my house for a month. My car been broken and I'm going delirious a little bit. So imagine a patient in the ICU, they're just stuck in this room the whole day. It's dark. They don't really know what's going on. Maybe they're a bit older and they're at a large risk of delirium for that. So reorient the patient. Hey, do you know what day it is? Oh, today's Tuesday. Let me open the blinds for you. Let me, like, the clock's in view. You write the day on the I almost said the calendar. You write the day on the board. You note the time of day, say, hey, breakfast is coming. Okay, now lunch is coming. Having a plan like blink your eyes, message board, if this patient's unable to communicate. Yeah, having some kind of communication system in place for you to communicate with this patient if they're able to. GI disruptions, GI prophylaxis, maybe TPN. Possibly, it depends what's going on with them. In terms of TPN, a lot of times if you have a patient and their GI is still functional, you want to go that route first. So a lot of times a big thing you'll see for the patients that are not really there with it, or they're sedated or whatever the case might be, a lot of times you will see these patients have NG tubes or feeding tubes of sort if they already had one inserted, but a lot of them have NG tubes. So if you have it, use it so you don't lose it. Let's see, is there anything else? There's a lot of stuff to keep in mind. Emergency equipment. Emergency equipment. Know where your crash cart is, please. You guys have the crash cart available to you in the skills lab. I know some of you were taken last week to go over like a scenario with via like your ACLS protocol with your boy Robbins. He's so cool. It's so nice that he does that. So knowing what's in the cart, what's in each drawer, how the meds go together, how you're gonna be administering them if you do, and then what should be in the room. So like always have your suction there, your tubing, make sure that the suction is actually functional, because I found that out the hard way because we didn't check the suction. So we had this poor lady, she was attached to a Pure Wick and the suction was not working. So you can see how that one went down. Didn't go down well. Your bag valve mask will always be in the room in your ICU patients. If they're at risk for, respiratory decompensation and possibly failure, knowing that your intubation is like nearby, your crash cart is nearby that patient's room. Think that's it. That's a lot from me talking, forgive me. Anyway, on to number 6. Your 87-year-old patient, oh, we kind of talked about it. Your 87-year-old patient's been in the ICU for 10 days now, believes they're at home and has become suddenly confused. What could be happening? There's a couple things. Delirium's definitely one of the things that could be happening.
The Lulu.
She's Delulu. Yeah, definitely. UTI, maybe some kind of infection. Look at this patient's age. They're definitely at risk if they were to get some kind of infection that could cause an acute mental status change.
Which is delirium.
I mean, yes, but I mean, like, what I'm trying to get at, like, what the causes could be for this, so to say.
So what's our acronym that's in
And
number
that's the next
7?
question. Wow,
Yeah.
that's crazy.
You gotta think. So what does it stand for, Ryan?
Dang.
On
We
your
think she's
test,
Delulu.
on your test, what are you gonna remember?
Wait, we think she's Delulu. I'm having too much fun, I'm sorry.
Cool, cool, cool. All right, who can help him out? Who wants to finish the last 2? Non-farm. Cool. What's the K? Yeah, for potassium / electrolytes. And then again, for the non-pharmacologic reasons, gave examples of dehydration, hypoglycemia, thyroid storm on there. All right, that's pretty much it. And again, the answers are going to be here. So when you have it,
Yeah.
you can come back to it, have the outline be filled out, and then come do the questions just to see yeah, then it kind of is a stretch, but
Stretch, but so is save. Let's be real. Come on.
no, that
I feel
one's
like
great.
save's a worse stretch.
No. Well, actually, maybe.
Yeah.
All right, so now we're gonna just talk about literally everything else. Kind of, yeah. Yeah, we're gonna just talk about the hemodynamics. Here's an example of a monitor. In here, I believe this is like the EKG. You have the O2 sat. You have your blood pressure, your MAP, MAP. I believe this is the PAP, so pulmonary arterial pressure, the mean pressure, mean arterial pressure, mean PAP is what I meant. Central venous pressure, respiratory rate, rhythms, the
Cardiac index, I think, at the bottom with that 1.7.
yeah,
Methinks possibly. Pulmonary artery pressure is the same as wedge pressure.
it is not.
No.
And we will talk about that as we go down, so we'll explain.
It's so confusing.
It's a little bit confusing, but we'll try to make it work. So, did you guys go over the Allen test in class with her? All
Is there
right.
anyone whose like hand did not reperfuse? That'd be kind
Bro,
of
you
scary.
spoiled it. You're supposed to answer what the purpose of it is.
Oh,
Exactly. Yeah. So the purpose is to allows us to determine if the ulnar artery.
ouch.
And why is it? Why? Because the A line will block the radial because that's where the A line will typically be placed. It'll be placed in the radial. So it's there to check to see if your ulnar it can do so. So how do we do it? We kind of block off both radial and ulnar. Have patient pump their fist until arm becomes pale or hand
And-
becomes pale, and then you want to um, let go of the ulnar and see how well it reperfuses. That way you're continuously blocking the radial and you get to see the return of color. Do you mean like they block you have excellent perfusion to your hand? Did they block both off and it never went pale or oh wow. That's actually impressive.
I'm concerned.
No, that's impressed. That's impressive.
How hard was the person pushing? It's my follow-up question. Oh,
Yeah.
okay. That'll do it. You have to really occlude that. Occlude it.
But yeah, let me see if there's anything else I can add here.
Text.
Pretty
Not
simple.
too much, yeah. It's
Yeah.
pretty straight up.
Yeah, pretty straight up. Here's a picture of the A line, so you can see it is in fact blocking off that radial artery. So yeah, let me know what is the purpose of the A line. What does it do? What are the advantages and benefits to having an A line? Yeah, that kind of goes into, so it's going to be continuous. It's continuous way to monitor kind of like blood pressure. Yeah.
ABG, so as well, it's a really great access point for that.
Yes.
I like that it said bags.
And
She got them bags.
all right, so kind of mentioned that. So the benefits, we mentioned that it's continuous, so that's a benefit. You don't have to keep pumping and stuff. Does the RN do the Allen test and not the MD?
I wouldn't be surprised if MD does it as well, but if we have any concerns about perfusion to the hand prior to possible insertion, then we can definitely do this test bedside.
Mm-hmm.
Helps us to titrate
Yep.
meds. Yeah, we could see that effect in real time as soon as we change, if we change our levo up or down, we can see the effect of that almost instantaneously via our A line.
Yeah.
Great resource if you have it.
So we're gonna be able to get the systolic blood pressure, the diastolic blood pressure, your MAP, which we will talk about how to get after, because I think you guys learned it last rotation. You'll still need to know how to do it.
Comes back for you. Wow.
And that's, don't worry too much about the arterial pressure tracing, but that's, I don't think it's in here, but just a
As
way
of
to read
right now, yeah, as of right now, there's no inherent need to know too much beyond that in terms of testing purposes. But if you were to go to the ICU, you'd have to know a little bit more about that tracing. But another day, another time.
Yeah. So in terms of here, it will also calculate your MAP automatically, which is good. But if you didn't have that, how would you measure your MAP?
Map. Map.
Math.
Right.
Well, you're gonna have to know the math.
Multiply plus 608 divided by 3.
Say that again? It's a little hard to hear.
I don't know if she knows that she's unmuted.
Isn't
Yeah.
it 1 systolic and 2 diastolic? You add those divided by 3?
Yes.
I mean,
So diastolic blood pressure plus systolic blood pressure all divided by 3. And you're gonna do this a few times in your test. So do not forget to do that, how to do this, because you will use it. Okay, so what's a an expected map, or what's like a minimum map? What's a solid range of what's considered good?
70 to 110.
Yeah, so 70 to 110 is good for fusion, and we'll say 65 plus is the minimal. Cool.
The
60 to
genius.
65, yeah, depends on who you're asking. So we mentioned that this is going to be continuous, helps us titrate some stuff. Cool. That's like the main real thing here is that it is continuous. Additional considerations, what are some things you're gonna have to keep in mind? So I can think of maybe like 3 things. What does damping mean? Damping? Yeah, so position changes, when you do have a position change, what do you have to do when it comes to the right? Keep it straight, so on the arm, you can splint the wrist. Sure. Well, let's say they actually do change their position because the arm explaining the arm makes it so you don't move it, but then you could still kind of reposition yourself and have it change, have the arm be higher or lower. Like when an A line is over damp or under damp. I've never heard of that, honestly.
I've heard of it. Yeah, I was like, it's in the YouTube, and like if you go, oh, another great resource for you guys is ICU Advantage. If you look them up. Trying to remember, I believe it does have something to do with the waveform. I don't know how to read it. ICU Advantage is awesome though. They have little practice quizzes too that you guys can look into. I don't think you need to know in terms of dampening at this point yet
Mm-mm.
though.
No, you definitely don't.
Oh, and that thing could definitely get dislodged. That's
Yeah.
crazy.
But for now, just think about how position, splint the wrist. So if there's a position change though, what else should you do?
Genius tax.
Anything you have to calibrate? Yeah, this one has a transducer. So you have to adjust the transducer at the phlebostatic axis.
Yay.
Where is the phlebostatic axis?
And she said, ow, the jump scare.
Something like that, yeah.
I've never heard that word in my life.
Oh, what, the phlebostatic axis? She not mention it in her thing?
It's mentioned. I feel like it's mentioned. I don't see it yet, ironically, though.
Hmm.
Am I tripping out? Is it not on our notes?
It is, it's right there.
Where? I don't know how to spell.
Or am I fucking mid cardiac?
Yeah, I was like, I'm pretty sure that's in week 3. I don't think because
Okay,
I
they
don't
don't
see
learn
it
it yet.
here.
Okay.
Yeah, I was looking through, I was like, I don't see that in our notes yet.
Okay, so we'll just say just adjustment. When you reposition, you have to readjust. Let's just say that for now.
Let's calibrate. Zero it out.
Yeah, just readjust and recalibrate.
Look at Miss Girl Bella on week 3.
Wow.
Dang.
So yeah, arterial bleeds, those get pretty bad because the major vessel
Arnar.
clotting and you're invasive, so there's infection. Another thing to keep in mind though, yeah, it's like you've probably seen it more than I have, Kaylin.
It's this little like thing off to the side. So you'll have your line, it's connected to this like pole that has these like stopcock things on it. And you have to recalibrate it there. So if you're gonna move the patient's head of the bed up or down, you would need to move that like device there. Let me just see if I could get a picture of it for y'all. What was I thinking about? What's the word for it? Oh, the line. Do you need to know how to calibrate it? No.
No, don't worry about that.
No.
I have a question.
Hopefully I have an answer.
For the A line, do you flush this daily?
Ooh, that is a great question. So
Oh
there
wait, you
is,
wrote it, sorry.
it's continuous flushing. Now, what is it continuous flushing with? It is not just NS.
Oh.
Yes,
When?
because like Michelle just said, it has a risk of thrombosis. So it's actually heparin as well. It could be just normal saline, but a lot of times it does have heparin. Is that part of this notes? I feel like it
Should be.
is. Saw it somewhere. I know I did. That's why I mentioned it.
Yeah, Ryan said it. Ryan said it does say continuous flushing, and then just a little bit more detail.
I got the picture. I got it.
What picture?
The recalibrating one.
Oh,
I got it.
okay.
There we go. Okay.
Oh, Jesus.
Haha. So you have your pressure bag right there. It's literally like, you guys, can you zoom in a little bit on that picture on the left? Yeah. So that little end piece at the bottom, the little balloon thing, it's basically the same ideology as your manual blood pressure cuff. So you're gonna puff that up and you're gonna have inside of that pressure bag, you're gonna have a solution. It could be NS, could be mixed with heparin, just kind of depends. And you'll pump it up to a certain pressure. I believe it's 300. I don't think you need to know that though.
No.
So that part's cool. And then if you go onto the picture on the right, you'll see this like machine looking thing. So you'll have the transducer, the holder for the transducer itself, and then like a way to recalibrate it. So you have this like kind of like how the what's it called? The NG tube in the skills lab, like the ones that are up against the wall, how you're able to like turn it off on, like the one with the four-way thing. Diego, do you know what I'm talking about?
No. Oh, yes, I do.
Okay, cool. I was like, I don't know the better way for that.
This
But you'll
it's called the stopcock, isn't it?
Yes, Lopez valve. It wouldn't surprise me if it's called a Lopez valve. That feels right. So you're able to turn that
Oh,
to
wow. Yeah, literally this.
thing. Yeah, that thing. It's just another. It looks a little different, but it's the same ideology.
Huh.
And you're able to turn that to relieve pressure and re-level it, and then return it back. So that is how you re-level it. Do you need to know that right now?
No.
No, but it'll make you look real smart when you get to the ICU. Haha. Okay, I went on a tangent. Goodbye. I'll put
Okay.
myself in the corner, don't worry.
Last thing would be just have a BP cuff on the bedside for confirmation in case something goes off. You're like, oh, that's a really weird number. Let me try it with the manual. But yeah, you want to have it in case of emergency so you can confirm. So you can confirm. Okay. And then keep in mind, when it comes to the PP cuff, are you gonna want to place it on the same arm that the A line's at? Yeah, you're not gonna
Yes.
do that. So avoid having the cuff on the same arm as the A line. All right. That's
She said
pretty
negative.
That's pretty much it. Anything else you want to add, Caitlin? I mean, we have complications, but we talked about a lot of these for the most part. In a different context, in the central line context, but it's practically going to be the same kind of idea. Maybe the only one, maybe the bleeding is a bigger thing here. So when someone's bleeding, you place blood pressure and call for help. If it's
Yeah,
it's a
so the
big
A line
bleed.
will have a continuous flush of sorts going through it to make sure that it maintains patency. So that's why you have that pressure bag up there. So it's pushing onto a solution. When I did it, there was at PIH, it was just normal saline, but I do know you can also have heparin in it as well. And that'll be pushing through to flush it.
All
Cool,
right.
cool, cool.
Any questions for them, Kaylin, on the?
I
on
do.
the- All right.
Even a question, my good sir. Of course I do. All right. It's kind of it's all kind of talked about before in length, but we'll just go through it. So number 8, you're attempting to determine adequate blood flow prior to having an A line inserted on your patient. What assessment finding would indicate inadequate perfusion? Do you know
Yeah.
if they have a Club Penguin emulator?
What?
I want to play Club Penguin again.
Did they take it down?
Yeah. The original site got taken out a long time ago. It was just something I was thinking about.
Probably not. I don't, I'm sure they do actually.
Eh, that's okay. Oh, yeah, I know, Tammy, it's gone. I'm so sad. But yeah, guys, like, I'm gonna be real. I'm a pasty girl. I'm pretty pale, but if there's pallor in their hand when you're doing that Allen test and you let go of that one side and it's still pale, it's cold, it's tingly, no good. We ain't doing it. As we know, that's really cruddy perfusion. So if it's pale or the skin color looks kind of off, it doesn't return to its normal color that it was beforehand. It's probably not the best idea to do an A line there. So let's see. I think that's it for that. Number 9, you're caring for that patient. They just had it inserted. What assessments are important for this? So we talked about it. So that hand color's one. What else? CMS, I love that CMS. Pulses, cap refill, CMS, assess the site for infection and bleeding. Bleeding. Let's see. Also stabilizing with that splint. Because if they move their wrist around, we can occlude it, and that's not going to get us our constant readings. Making sure that that device is level at the phlebostatic axis. You guys will learn more about that apparently in week 3. And then obviously we have the 6 P's as well. I like the idea of the 6 P's
Six
for that.
P's.
6 P's. Additionally, we put the A line in place. Why did we put an A line in place? What's the purpose of it? Yeah, frequent monitoring pretty much. With your blood pressure, your map. Yeah. And if you're titrating meds, that's a great way to do it as well if they do decide to go that invasive. So it's really looking at your map of it all. And then having your non-invasive blood pressure on the opposite side just to check for accuracy, especially after you re-level it. I think that's it for that question. So on to number 10. So we're going to be calculating a map. Yay.
Wow,
So,
math.
wow, math. We love that. It's 6:30 at night. We're doing math. Yay. So you have a blood pressure 87/45. What is the map and is this sufficient?
Yeah. Keep in mind your questions won't be like simple as like that. It would probably be like, here's our blood pressure, and then you're gonna have to determine uh you're gonna need the number to then do the question in the first place. Kind of like that.
Oh, yeah.
Yeah, and then don't forget that the ExamSoft has a calculator button somewhere on any question. Even I think I remember that during the test there were some questions that are clearly like you need to do the math, or like the button for the calculator isn't immediately there, so you had to click on tools to find it. So just keep that in mind.
I feel like you're specifically saying it because it took you halfway into 240 to find that.
Yes,
Love that for you.
and I did the math in in my head.
I
So I'm like, I
cannot
don't.
believe you managed that.
I'm like, I
Heck
don't.
no.
Like, where's the calculator?
I don't even know. But yeah, so 87, so it's our systolic plus 2 times of our diastolic, all divided by 3. So 87 times 2 times, or plus 2 times 45, all divided by 3. That gets us a number of 59. We know that is too low. Our absolute minimum for perfusion is going to be 65, so this is not adequate at all. And yes, I would have died if I had no calculator too. No, thank you. I'm personally good. Oh, look, a bad scenario. Gosh. 11, you're answering a call late for your patient with a newly inserted A-line. Upon entering the room, you note the A-line has been removed and note a large amount of blood on the bed. What's your first action? Pray or cry is not on here. I'm sorry. That was rubbish. I'm sorry. Pray. Oh, awesome. Two at once. Two at once.
Pray, cry, pray, and cry.
Oh, you're terrible. Yeah. I think, and this is a go on lunch. Oh god, not my 1-800, not my package. Oh, this is horrible. I love it. 10 out of 10. But yeah, like this is a pretty obvious one, right? Like we walk in, they're bleeding, it's like, oh my god, I need to hold pressure. So yeah, B is correct. Apply pressure dressing and hold pressure. This is a pretty straightforward one, but I also want to specifically note here that be very cautious of what it's asking you in the questions. What's your first action? What's your priority? Um, when you get stuff like that, for the most part, it's usually asking you like, what can you do actually in the room? Because most of the time, it's not going to be called the doctor, because I mean, unless we absolutely cannot do anything. But if there's something we can do that first before you go and notify the physician. Because imagine sitting there, they're bleeding out, and you call up the physician. Hold on, real quick. Let me just make a quick phone call. You're outside of the room. They're still bleeding. Like, it's not too good. Not a good idea. But yeah, for any of your questions from here on out, when you get that priority action or what are you gonna do, just always consider, is there something I can actually do for this patient right now? Or if there's absolutely nothing, do I just call the doctor? So I think, is that it for this section? I think that's
Yeah.
it. Yeah, that's cool, cool, cool.
So going
Cool
back
beans.
up. All right, so this
Hands.
is them talk about the Swan-Ganz catheter or the pulmonary arterial catheter. Here's a picture. This is like a screenshot from the ICU Advantage video. You don't need to know it to that deep because he talks about like the blue port is this and the yellow port does that. Doesn't have to be anywhere near that deep. Jessica says, so if the patient's having signs and symptoms of pneumothorax, since we can't place the CT, what are we supposed to do in the room? I would say if they're having those symptoms, elevate head of bed oxygen, call for help, rapid, or just like get someone there to um get that guy a chest X-ray, and then the doctor will do the chest tube, blah blah
For
blah.
help.
Yeah.
Yeah, so I mean, like if if it hasn't been fully confirmed in the question, if it's a pneumothorax as well, like, is there further question if there's a further assessment that you need to do? I like the idea of calling a rapid for that case. We are not allowed to place the chest tube. So at that point, like, especially when you have like a tension pneumo, right? So our trachea is being shifted off to the side. That's a true emergency. If we get something like that, there's nothing we can do. At that point, it's pray and you call somebody, like it's dependent on the situation, how much information you have, what's going on. I like yell for help though. I like that idea.
Yeah.
Yeah.
So what is the purpose of Swan-Ganz?
Swans.
Yeah, basically it's going to be one of your key things in measuring hemodynamics. So that's the name of the lesson essentially. So we'll do some of these, and some of these. All right. So some of the features. So list me some of the values that it can help you get specifically, and then we'll try to talk about them as they go. Oops, CVP. Okay. So we have, yes, so LVED and the PAWP are the same things. There's PAP, there's PAWP. And we can also get the cardiac output as well. Yeah, so pulmonary arterial pressure, there's the pulmonary arterial wedge pressure and the central venous pressure. Okay, so we will talk about the values. So here I have like a little thing. We'll kind of go a little bit back and forth here. Yeah, so PAWP, the pulmonary arterial wedge pressure, is the same thing as the left ventricular and diastolic pressure. So these are the same thing. A lot of letters. We'll talk about for now, let's just kind of talk about some of the values. So what are the values that you were told to learn when it comes to the cardiac output? Yeah, so if it's gonna be a 4 to 8 liters per minute. All right. What about your CVP? That's gonna be a 2 to 8, yes. And someone already went ahead and said the poppy. I like calling it poppy because it's like a puppy. I like poppy. All right. The PAWP is 4 to 12. All right, cool. And I will talk about as well ways that I kind of remember it. So I think of the central venous pressure. This is essentially your um right atrial preload. So it's the pressure coming in. That's basically the preload, the pressure coming at the start of the heart, your central venous pressure. The pressure from your veins as they're coming back into the heart. Yeah. Your oh, sorry. This was meant to be here. Sorry. There we go. Sorry. Good catch. So your CVP, I like to think of it as the right atrial preload. So it's the pressure at the start of the heart. It's the preload at the start of the heart. So as we'll talk more about these will start to make, I think, a little bit more sense. Your pulmonary arterial pressure is going to be essentially the right ventricular afterload. So this is the pressure that you have in your lungs. So for the heart to make its way all the way across, it starts in the right atrium, makes its way to the right ventricle. So that CVP is essentially the pressure in this right side of your heart. Your pulmonary arterial pressure is essentially the pressure in your lungs. And because we know that the right ventricle goes into the lungs, that PAP is the pressure that your heart has to fight against to make it to the lungs, which is why it's the afterload, because that's the definition of the afterload is the pressure needed to be essentially beaten to make it across the finish line. So your pulmonary, I'll write them out so it's not as confusing. Pulmonary arterial pressure. This is the pressure in your lungs, essentially. And this is the pressure your heart has to beat to make it to the lungs. Okay, so this is pressure going into lungs. Your pulmonary wedge pressure is taking, is essentially kind of like an estimate. It utilizes the little balloon at the end of the catheter. It essentially pumps up and occludes it. And because of the occlusion, we're able to see essentially the pressure happening in front of it, essentially. So kind of think about like the balloon here. Let's say you're able to measure the pressure. Oh, someone's pinging me. You're able to measure the pressure past it. If you wedge it out, you no longer get the readings from whatever's behind. I know that's really confusing. Essentially, you just got to know is that the balloon being active in here is going to allow us to guess, kind of get an estimate of the pressure in the left side of the heart. So the pulmonary arterial wedge pressure, the wedge referring to that occlusion, this is essentially going to be the I would call it the preload of the left ventricle. So this is the pressure that's now going into, it's made its way past the lungs. And now the pressure that's coming into the left side of the heart, that then will make it out to the body. I know that's probably really confusing. Any confusion on this? I'm just trying to kind of show how these readings kind of show the way the pressure moves around the heart and that whole system. So your CVP, yes, it's also it is also called the pulmonary arterial occlusive pressure. And it's also called the left ventricular end diastolic pressure, or the pulmonary arterial wedge pressure. So all of these are the same thing. PaOC is the same thing. It has a billion names.
Horrible. There's so many names.
Yeah. But that's the concept. So again, your CVP is essentially your preload that's coming into the heart, coming back from the body back into the heart. So that's essentially how much circulation you're playing with. It has to make its way through the lungs first, come back to the left side of the heart to go back into the body. But it's kind of what you're starting out with. It's your start. This is like the start of everything, the start of the process. For it to go from the right side of the heart and make its way across, it has to pass the lungs. So it has to fight this pulmonary arterial pressure. Do you guys remember when you guys were learning heart failure, there is such thing as a pulmonary hypertension, and a lot of right-sided heart failure can come from pulmonary hypertension. Do you guys remember what I'm talking about? Yeah. So let's just for the picture's sake, if you guys can see my mouse, let's say um the lungs are right here. Let's say this circle is the lungs instead. So blood is over here. This is your CVP, the pressure that's in this right side of the heart. It has to fight the pulmonary arterial pressure. There's a pressure here that this has to fight to make it to the lungs. So those people with pulmonary hypertension, the pressure here in the lungs, the pulmonary arterial pressure is so strong that the right side of the heart can't fight against it and make its way across. Because it can't fight against it, all that pressure or all that blood starts to pool on the right side of the heart. Hence why pulmonary hypertension leads to right-sided heart failure. Even though I know we like to associate left-sided heart failure, we associate left-sided heart failure with pulmonary edema. It's like a common mistake people make is associating like pulmonary hypertension with left-sided heart failure, but it actually is associated with right-sided heart failure, hence why right-sided heart failure is also called cor pulmonalis. So a lot of your COPD and other pulmonary conditions can lead to right-sided heart failure is because of that connection there, because it leads to pressure in the lungs. And if there's pressure in the lungs, your heart can't fight against it, and then there's pooling of the blood in the right side of the heart. Does that make sense? Any confusion? This is just all for context. It doesn't go this deep in the class. It's just for context. So you guys kind of understand what these values are actually referring to. So again, CVP preload, essentially your preload of your right side of the heart at the very start. Pulmonary arterial pressure is the pressure in the lungs. Yeah,
Wedge
so
pressure.
so the wedge pressure. So I actually haven't even gotten to that point quite yet.
Oh.
But when it comes to the wedge pressure, long story short, it's not a direct estimate of the left ventricle pressure. It's like you utilize the balloon that's in here. So you see this white circle, it's the balloon. The way that it works is that you have this sensor. It senses the pressure throughout the pulmonary artery. So you get everything that's happening, everything that's going on through here. If you notice here, the catheter actually continues past the balloon. So when the balloon's inflated, it doesn't really make a difference. You have the pressure of this whole thing happening. But when the balloon is inflated, and that's one of the things you can do is you can inflate the balloon to create that occlusion, hence why it's called the occlusive pressure or the wedge pressure. What that leads to is essentially once that balloon is inflated, the catheter is taking the pressure readings from everything that goes past the balloon. So it starts ignoring everything below it, everything behind it. So because how deep it is, by ignoring everything to the left, you end up ignoring the pressure, that afterload pressure, and just start looking at the pressure that comes after it's made its push through into the pulmonary artery, if that makes sense. So essentially, by putting the balloon up and then reading the pressure readings past the balloon, you get the pressure that you would get, the pressure of the blood that's already made it through the pulmonary artery that will essentially come back and make its way to the left ventricle, which is really confusing and you don't need to know it that to that level. So, which is why all you really need to think of it is that this is essentially the preload of the left ventricle. So these are the best, I think the best ways to think about them. Because the whole explanation of why the balloon makes it work, why the balloon is able to cause the explanation, or why is able to cause that reading is kind of complicated. So it's easier to um, just kind of know that balloon being on means you get the pressure on the left side of the heart. Yeah, it's above your pay grade. You don't have to know this. It's way above your pay grade. You won't be tested on anything like that. This was something a lot of us were confused about, and it was never that deep. So it says high wedge is like left heart failure or hyper. Yes, yes. So yeah, so low is dry, high is wet for CVP. So we think of that like low. So we have that 2 to 8. And low is, you want to think of it as dry because this is, again, this is your preload essentially at the start of the heart. So if we don't have enough of it, it's saying that we have hypovolemia. We're hypovolemic. We don't have enough fluid. We don't have enough circulation. This is your, again, your pressure at the start of the heart. If it's low, it's because we don't have enough. We're hypovolemic. There's not enough perfusion. If it's high, that means we're wet. It means we're hypervolemic. We have a lot of stuff going on. We don't focus in this class, we don't focus as much on the pulmonary arterial pressure. So you don't need to know really much that goes on with the PAP. With that one, um, yeah, you don't need to know it really. The only thing that at the top of my head I know about PAP would be that that's the pulmonary hypertension. You can use it to determine pulmonary hypertension because that's literally the pressure in the lungs. So focus more on this value. You're gonna have questions where they give you a CVP and you're gonna be like, all right, what do you do? CVP of, you have a CVP of 8 or a CVP of 10. What do you do? So what do you do? So when we are hypervolemic, what do we want to do? Yeah, so we want to use diuretics uh, to reduce. And if we're dry instead, yeah, like it, then we're going to give fluids. So we're going to give bolus. And if we know that that's the preload at the start of the heart, we know that that's everything that your heart has to make everything happen. So if it's really high, we have too much and it's going to overload the heart. If we have not enough, then the heart doesn't have enough to make perfusion happen appropriately. Okay. Anything else? Okay. And then your PAWP is you can kind of think of it pretty similarly. This is the pressure that makes its way. It says 4 to 12. The pressure at the left on your left side of the heart. So the pressure that builds here So this is then going to fight against systemic vascular resistance. So if, yeah, so yeah, vasodilator versus vasoconstrictors, because those affect, yeah, this is like the preload of the left ventricle. So this is how much you have to play, how much fluid you have to play with. And then this is how much you have right before we're gonna go pump. So this is, yes, this is what's going out out into the body. So this one fights systemic vascular resistance. Systemic vascular resistance, SVR. I would also consider this left ventricular afterload. So this is the pressure that your left ventricle has to fight to make it through. And we know vasodilators, vasoconstrictors, these are going to affect the afterloads more than anything. So hence why if someone has like a really high PAWP, that's when you want to consider the vasodilators, because those are going to affect the systemic vascular resistance, because that's what this is directly fighting against, because it's fighting the afterload. Because and we know that vasoconstrictor, vasodilator, for the most part, is going to affect more of the afterload than anything else. So let's see what else we can talk about here. Okay, what else? Vasodilation, yeah, because that would help with the afterload. But there's also some things where that might not always apply, or where it's like some conditions that you'll learn in week 3, where, for example, cardiac tamponade that you'll learn about. You have like a general rule, and then there's some conditions where you don't follow that general rule. Yeah, so let me see if there's anything else that I can think about. Okay, how about this one? I don't know if he's mentioned this before, but it might be in week 3 instead. But just for reference, you have right-sided heart failure, and in general, or I guess sorry, you have with MIs, you give your Mona. If people have right-sided MIs, so that would end up causing issues with the right side of the heart. For example, you might not want to give vasodilators because it takes away some of their preload, and they need the preload to function. It gets a little complicated, but I think once you guys get through week 3, it'll make more sense. But for
I was like,
now,
yeah, for now, these are general.
yeah,
Definitely
exactly.
depends on the type of shock. Everything of this is very general right now. Once you go further down into the weeks, you will get more specifics in situations. These are not always as clear as black and white. Pulmonary hypertension relies on wait. Oh. Huh.
Not pulmonary hypertension, but so the thing I mentioned was with the right-sided MI.
Oh.
You might not want to give the nitroglycerin, because then it makes it harder for them to get preload. So with that one, it's its own like specific case. Yeah.
Pretty much, yeah. So if you have anything where, like any certain situations where the right side of the preload is already trash, um, we we wouldn't want to do anything like that. So with your right-sided MI, your preload on that side is already trashed out. So that's why it was only lightly gone over with Salazar and 232. And again, you still don't really need to know this, but it's just a cool thing to know, I guess. That if you do have a patient with that right-sided, they rely on that preload because that side's already not receiving a lot. So if you were to give something like a nitroglycerin or cause less to return, less preload, you're basically gonna send them into like, what is it, like a cardio? She talked about it in clinical, I'll be darned. Was it like my brain wanted to say cardiogenic shock, and I don't think that's right.
For
If you were to give someone with a really cruddy right side preload for right-sided MI, if you were to give them nitro, you don't need to know, this is too much.
cardiac tamponade, you want to give them, yeah, you still want to give them fluids instead of,
But-
yeah. What am I thinking of cardiac? No.
I don't know, this is too far.
Yeah.
We're going too
Anyways,
far.
yeah.
Oh yeah.
Yeah, but then there's the exception when you have certain things. Yeah. So anyways, I guess the way to think about it is it's kind of a cycle though. So we talked about how the vasodilators are going to affect a lot of this systemic vascular resistance, but then remember once it does get past, once the blood gets pumped out, it makes it past that systemic vascular resistance. Those vasodilators are having an effect on the systemic on all those systemic vessels, all the vessels that are outside of the heart, and then they're the ones that over time make its way back here. So it's like a cycle. So once they make its way back, because you lowered the pressure, the afterload, once it makes its way back, it also means you have less pressure going back in, if that makes sense. So because you lowered this, it means that now as it cycles all the way back here to become what's going to become the CVP, it's lowered as well because you vasodilated. Does that make sense? So with the vasodilator, it makes it easier for the left ventricle to go, but then that pressure is lowered systemically. So as it's making its way around to then go back to this cycle where it goes CVP, then PAP, then preload, and then this one, and then back to this one. It ends up decreasing the preload because it's like a big cycle. Okay. And then we have cardiac output. Not much else to really think about. It's just the cardiac output. Just know the numbers. Other than that, it'd probably be knowing. Yeah, I guess knowing is. Did he talk about crap? Did he mention crap? He has not. Okay. All right. So what's crap? What's? It's an acronym. So these are things that are going to be good for maintaining cardiac output.
Queen.
So yeah, it's going to be contractility. The R stands for rate, so referring to your heart rate, your afterload, and then your preload. So all of these are going to play a part in maintaining your cardiac output. So how well the heart contracts, that makes sense. That's why we have those positive inotropes that help your heart, the digoxin and whatnot. The rate, if your heart is beating more, it's gonna increase your cardiac output because if you remember your cardiac output is your stroke volume times your heart rate. So if this number goes up, cardiac output's gonna go up. But it also has like diminishing returns. So at some point, if the heart rate's too fast, then those pumps are like little they're not strong enough. So there's diminishing returns. We'll go over that later, but in general, increase heart rate will increase your cardiac output. Exactly, not enough time to fill. So that's some of the issues you have with like fibrillations and fluttering. And then yeah, management of the afterload. So if we increase the afterload, sorry, if we decrease the afterload, we end up having an increase in cardiac output, which comes into play for something in week 3, which is interesting, but we'll talk about that when we talk about it. And then your preload, which if depends on how we are. If we are hypervolemic, then we can lower the preload to improve cardiac output. Because if we overload the heart, it's not going to have a good time either. Or we give fluids because we don't have enough of it. So essentially, these are all the things that, yeah. So let's see what else might be important. I wrote some things here, but I guess you don't. I don't know if it's really too relevant, but I guess I kind of mentioned it later on. So we have central venous pressure. We talked about that. Pulmonary wedge pressure. We talked about how that's essentially the preload of the left ventricle. Okay. So when that, and you'll learn, you have like a very specific like week 3 hemodynamics. Well, you'll go into a bit more detail, but right now I'm just giving you guys the basic understanding. I think your main one you're going to be really tested on is your CVP. You should still know each other ones, but you'll probably have questions where you're going to interpret the CVP and determine what to do. So just keep that in mind. I have something that says considerations. So it's inserted. I'll just kind of fill it out because I just want to make sure that we can finish on a solid amount of time. It's going to go in through a central vein. Could be in place for several days. So some other things that we're able to do, we're able to assess all these pressures. We're able to do like a thermal dilution. So we're able to inject fluid to determine the cardiac output. So that's how we do that. So I guess I'll write it down. I'll kind of just copy paste this because this is from the video and it's just there for context. It's not, I don't think you get tested on cardiac on this, but the idea is that you were able to put fluid into the catheter and then record the change in temperature. The idea being that if that fluid had less time to warm up, it means you have better cardiac output because your heart pumped it out so fast it didn't have time to
Change.
the change in temperature before reaching the little thermometer there.
Mm.
So that's just thing to keep in mind. You can place medications through it. You can, it has a balloon port, so kind of yeah, in the video he talks about the different ports, but it's really unnecessary to have to know it that deep. All you need to know is that there is a balloon port because there has like a little balloon. You will put in some air, and doing so will allow you to occlude the pulmonary artery so you can get the pulmonary
Pressure.
wedge pressure. Yeah, and then yeah, cannot infuse more than 1.5. Yeah, I don't think you need to know any farther than this. So I know that because I remember when I was here, I was taking notes on the ICU Advantage video, and it was really extra, and you don't need to know. You definitely don't need to know. The yellow one does this, the blue port does this, the white port does that. So don't worry about it too much. And then when it comes to complications, a lot of the time it's like all the same stuff that we're already kind of aware. I'll change this to, yeah, I wouldn't even bother too much. Yeah, it really, yeah. I did have a little section here. We talked about stuff. These are the numbers you're gonna have to know for 240, and then I included a few extra just because I'm a nerd. But I'll spare you guys. I'll write it down for week 3. We've been here long enough, so those were values that didn't come up at all in class. but they're values that the Swan scan catheter can utilize. So things that get skipped over here is the PAP. So we don't talk too much about the PAP, but we talked about how the PAP can be measured to look at pulmonary hypertension. Okay. What else can this thing do? What else did I? Oh, we talked about the systemic vascular assistance. You don't need to know the number for it. And then there's another thing the catheter can do, which is get you the mixed venous oxygen saturation from like a blood sample. And with that, you're also able to determine how good your circulation perfusion is going, but you don't need to know that for this week, and you don't really need to know it much for the class. So I'll kind of just erase that for now. And then here, have a list of some of the medications that come up for you guys to know. And you guys will go again. Week 3 is like a big,
Dynamic.
like considerably more clarity and more detail on everything here, but you're not tested on week 3 yet. You're tested on just week 1 hemodynamics. So I just think I'm just gonna put the very basics when it comes to the vasopressors, which I don't think you guys probably went over very much.
Sure.
So when it comes to norepinephrine, dopamine, and epinephrine, norepinephrine is going to be, we're just going to say it's going to make the BP go up.
And yeah, that's your
Dopamine,
lethal.
yeah, dopamine is your heart rate and BP up. And your epinephrine is going to be your heart rate up. And then with a
Smidge of BP
smidge, yeah, smidge up at higher doses. So that's as far as you need to know
for now.
for now. Yeah. And then you have some of your inotropes. So we know digoxin is going to make the heart rate go down, contractility go up. Your dibutamine's going to make your heart rate go up and contractility go up. Milrinone is going to make your contractility go up. And I believe this one can make your blood pressure change as well, but I'm going to go double check myself on that. Do you remember, Kaylin?
I do not remember. Forgive me. It's of non-importance right now, though.
It's not, yeah, it's not important, but if you see it, you'll know. So let me see. And some antiarrhythmics, you guys can read up on what this kind of mentions. So you'll see some of these come up in week 2.
Oh, he died.
Oh no, my nephew's just being really loud. So we said contractility, heart rate goes up. We have reflex hypotension. You'll learn more about that later. Milrinone. Yeah, BP down. So BP down, heart rate. I think heart rate up, contractility up, heart rate up. Okay. But I will just focus mostly on these, just kind of knowing the difference and how they affect the body. So norepi is BP up, dopamine is heart rate and BP up. Does both, so it's dope. I don't know. Epinephrine, heart rate go up. Actually, I remember once you guys get to week 2, I do have like a fun way to remember epinephrine in one of the algorithms that I'll talk about later. You guys went through week 2 this week, huh? Or I guess tomorrow you guys start or I guess today, what day is today's Wednesday?
It's Wednesday. They had a lecture today, so they had part of EKG and
Oh, cool.
today and tomorrow.
Cool. Did you guys go over what you're supposed to do when the patient is in asystole?
Feel.
Cool. CPR. Awesome. Yeah, so I guess I have a way to remember it. That I'll get to that, but just for now, I just kind of I have it written down because I'm like, oh, I thought about it. I thought of it while doing my ACLS. I'm like, oh, this might help people. So basically every epinephrine is a drug that will come up a lot in your algorithm. So whenever you have to do CPR, you have to do compressions, epinephrine's involved. It's always going to be involved. So when you're doing high quality compressions, it's you're being epic is what I remembered. And epinephrine has the word epi in it, epic epinephrine. So whenever you're doing compressions, you're always given epinephrine. 1 milligram every 3 to 5. That's correct. Because then there's the different algorithms. If you have pulseless VTAC and if you have BFib, you give a different combination of medications. For example, you don't defib and asystole, you just give epinephrine and compressions. We'll talk more about that as we get there, but yeah, I just wanted to share my way to remember the epinephrine. No, I don't think it was received that well though. I thought it was cool. And then lastly, oh wait, you have questions, don't you, Caitlin? Like,
There's only a short few. So you're caring for someone with the swans inserted. You note their CVP is 1 with the general information. What is this assessing and what could it mean? Yeah, so our CVP could be an indicator of fluid status, not always, but for general purposes right now, we're gonna say that our CVP is measuring our fluid status, and this with this reading provided, this could be hypovolemia, patient's a little dry, so we know we need to rehydrate this person. Cool beans, guys. Number 13, you're attempting to determine the pulmonary wedge pressure. How would this be measured, and what are some considerations when you do this?
yeah, this is something that we did not talk about. Sure, it's measured with a swan scan. So what did you do
We
with
did
the
not
swan
talk about it.
scans?
I thought you did. I remember hearing a wedge pressure a few times, and I don't know. I thought you did.
Yeah, we did. I mean, we talked about, yeah. So keep in mind that the pulmonary wedge pressure is not something that is continuously monitored because it's you have to pump the balloon. So if you have the balloon wedged, can you keep the balloon wedged continuously?
Yeah.
Yeah, no, because then we kill them.
Only
Um,
temporary.
yeah, so it's a temporary thing. You're blocking the blood flow exactly. So that pulmonary wedge pressure is an on-demand thing that you obtain. So yeah, it's is that pretty much all you were going for, Caitlin?
Pretty much. So just using, you don't have to know. Yeah, the syringe is a special one. It's a 3 ml syringe.
Mm-hmm.
It'll be filled with 1.5 mLs of air. If you overinflate it, that's not going to go too well for the patient. You inflate it with that 1.5 mLs of air. You occlude the pulmonary artery so that you get your wedge pressure. After you obtain it, you release it, make sure all of the air is out of it. I'm trying to think, there was one more part of this.
And you don't always inflate the full 1.5. If you feel resistance, then you stop. I don't know if you already said that.
I did not. I don't think there's anything more that they need to know
Pretty
at this
much.
point.
Yeah. All right. So then, when it comes to mechanical ventil, yeah, probably. I can't imagine. Well, yeah.
Hopefully so.
Yeah. So then when it comes to the mechanical ventilation, you guys will learn way more about this than you probably want to, but you'll have to learn more about this. I think it's week 4.
It's week 4, so right now you guys really just have to know the VAP bundle at this point in time, and you'll get more information on week 4.
What does it mean there's resistance? It just means you filled up the balloon. The balloon already fully occluded. So maybe, everybody's body's different. So maybe um my pulmonary artery is a little tighter than someone else's, so it doesn't require as much air to occlude. But the reason you don't want to keep pushing is, what if you cause too much and then you cause some damage or whatnot.
My kind of luck.
So VAP related. What was the question, Caitlin?
I didn't ask a question. I was
Oh.
just I was saying that what they need to know right now is the VAP bundle. So ventilator associated pneumonia and its prevention.
Yeah.
So that's called the VAP bundle, and there's certain things that go into that.
All right, so go ahead and list them because you will have to literally know this.
No,
And
no,
you,
you're good, Josh.
yeah,
This is good.
and you might have to do a SATA question.
Yeah, she says sedation, vacation, oral care.
How long oral care? Or how often oral
What?
care?
Q2.
Yeah. If it
The,
says oral care 4, it's wrong. If it says oral care 1, it's wrong. Um, what else did we say? E2, yeah, E2, ET suctioning. It's kind of like a Q2
mm-mm.
slash PRN. So
It's
you
more
don't,
PRN.
it's more PRN. So when it says Q2, it's kind of like a PRN med. It could be Q6, but it doesn't mean you're always giving it every 6 hours. It's just every 2 hours you're allowed to do it again if you determine it's PRN, if that makes sense.
Q2 is a very common thing, I feel like, yeah. But yeah, your ET sectioning, it's really only when it's indicated, but like he was saying, Q2, if you are doing it routinely, if the patient truly needs it routine, then it would be Q2. But you don't want to do it more than necessary because we might cause more irritation to the area and might cause damage if it's not even warranted, and risk of infection as if it's an open suction, then we're definitely opening that up to infection risk and bacteria and stuff getting inside. So your ET suctioning is technically PRN, but Q2 if you need to do it more often if it's indicated to.
Yeah, does this make sense so it's not confusing?
Because your girl thought it was Q2.
Yeah.
My bad.
So what else did you guys mention? Oral care, sedation, vacation, that's good. So
Sedation vacation.
what else is indicated in your VAP bundle?
Whoop.
There's at least 3 things, at least 3 more things. So if someone's on a ventilator, how do you want them positioned?
Also prophylaxis too.
Yep. Yeah, so you're gonna give them peptic ulcer prophylaxis, so that includes essentially peptic ulcer
Head a bed
prophylaxis.
up, definitely.
So we're gonna have PPIs, H2 blockers. So do you remember the prefixes just in case? So PPIs are the like omeprazole, so prezols for PPI. H2 blockers are like the deans, so like for example, famotidine. Example, omeprazole. Okay. Head of the bed, yeah. So we're gonna want the head of the bed elevated, at least 30 plus degrees. And then just if the patient's on a ventilator, they're not moving very often. So what do you want to prevent?
Yeah, I mean DVT is
Yeah,
technically one of them.
yeah. So DVT prevention. So your your subacute heparin, subacute Levinox.
I thought you were going for pressure ulcers too, which I
That's true.
realized technically it technically is not part of ventilator bundle care because for the bundle care it's specifically for, well, I mean it's not specifically for pneumonia because
Kind of
it's,
is because that's what BAP means.
well, I'm trying to
Until
figure out why DVT prevention's in it.
oh, fair.
That's why I was like,
Like,
that's kind of odd. But yeah, it's supposed to be for pneumonia. But yeah, you for these patients as well, they can't move themselves. So pressure ulcers is something we really need to watch for as well. Because,
true, I
Brian,
guess.
that makes sense. You're so smart. Makes so much sense. It's late. I think I need a nap.
Nail care emoji. Let's go.
Queen.
Queen.
Okay, so that makes sense.
Yeah, and there's nursing considerations. I'm gonna speed things up because this is just gonna be things that pretty much anything that it comes down to when it comes to respiratory oxygenation. So lung sounds, respiratory rate, effort, SATO2. One of the things that you guys learned that you probably didn't know about is your end tidal carbon CO2. Um, Essentially, that's a way that they can determine that they're actually in the right place is because the CO2 is being released. So that can be something that gets measured. So if it's uh, that could also be there to like measure how is the ventilation going.
During ventilation, making sure you're in the right
Mhm.
place on insertion, on ET tube insertion, and throughout the time that they have it.
Yeah. So like you'd be able to tell if they're being hyperventilated, hypoventilated as well. Um, and here it mentions the lip line, so you're gonna keep just like your NG tube, you're gonna note uh where it peaks out essentially. Like where was it? When did it reach, like at what point is it at the lips? As opposed to like an NG tube where it's like at which point does it exit out the nares, or where did I mark it? You're gonna need to know your vent settings. You'll learn more about that later. And then pretty much when you think about oxygenation, you think about, is their airway good? Oral care, condensation, that refers to like you can have like humidity and fluid build up, and then you don't want that. You're gonna want to get rid of some of that, um, so that it doesn't make its way into the lungs, because it's that tube can gather that humidity, um, and then if it goes into the lungs, that's not good. So keeping track of that, trying to decrease aspiration in general. Something that maybe you don't think about is that they're probably going to want to be restrained, because if you're sedated and then you just kind of get up and then you're have a tube in your mouth, your first instinct is probably to be like, what in the hell, and then try to rip it out.
Yeah.
So people get restrained so that they're not able to essentially kill themselves by taking away their O2 and harming, like causing damage to the trachea. And then lastly here is going to be emergency equipment. So what do you guys want? What do you guys think is appropriate to have for a patient on a ventilator? Yeah, so that's going to be your big thing. It's going to be your ambu bag. So for rescue. So if this person is, if there's some sort of, you'll learn more about like the alarms. So if there's some issue with your ventilator, it gets you an alarm and you don't know how to fix it, yeah, you can go ahead and use the ambu bag to rescue the patient while you're trying to figure things out. Suction is also an important thing to have at the bedside. So you're gonna use that to, it's already kind of mentioned in your VAP bundle and whatnot, the obturator.
Obturator. Smooth obturator.
Any
Sorry.
questions on anything we've done so far?
I got that.
Yeah, but I think obturator is more for trach, not so much the ETT.
Yeah. Obturator is going to be for your trach if they have it. So it's depending on kind of it's circumstantial.
Mhm. Any questions on anything so far? I feel like the muddiest part was explaining this, because this is actually pretty complex, but you don't need to know it in this complex way. It's just, I do think knowing what the CVP actually is helps, instead of just kind of memorizing, if this number low, it means I do this, and this number high, I do this. Because I think it also helps when you guys get to the week 3, when you have like the cardiac conditions and the shock, cardiogenic shock, it explains why these numbers are the way they are. Any questions on anything else? So swan scans, any questions on this explanation? Any questions on um, the IV meds? Any questions on the VAP bundle or with the A lines? And if you do have questions, just message me on Pronto and I'll try to explain it, because I imagine there's probably more questions on this um, during lab time. Tomorrow I'll see you guys at your 12:30. So if you have a question on this, I can explain it a little bit better with the whiteboard. But it is kind of, again, a little extra, but I personally like having this stuff here because it helps me to understand what I'm measuring and why it's good to measure it. So for example, like your PA, if you know that this is the preload of the left ventricle, if this number is really high, we know we have a lot of fluid in this area. And then we could be like, oh, that's related to heart failure, for example. So a high PAWP is showing that there's a lot of fluid in here, a lot of pressure from fluid here. So we know, oh, that's left-sided heart failure. When we have cardiac tamponade, we have fluid overload. that your body, you're to the point where we can't pump anymore. So it makes sense that, oh, this value, if you have fluid, your heart's completely overloaded with fluid, it makes sense that the value that determines fluid pressure in the right side of the heart and the left side of the heart are both elevated, and et cetera, et cetera. So if you have any questions pronto or tomorrow at 12:30, and we'll also be there to help you work on your insertion of IV start and whatever else you need.
Time is your guys' math exam. I know that's tomorrow as well, right? Do I remember how this quiz 12:30? Oh, okay, so I guess a little after 12:30, whenever you guys come back out.